You can see the announcements up top. And then I just want to call your attention to two really exciting talks we have coming up in the next couple of weeks. So October 29th, we have an endocrinology grand rounds by Dr. Jose Flores. Dr. Flores is the physician-in-chief and chair of the Department of Medicine at Mass General Brigham, and also an endocrinologist and presenting for us on October 29th. After that, on November 5th, we have a very special presentation by Rochelle Walensky. Many of you will know that name. Rochelle was the past CDC director in the Biden presidency, and also is a very well-known HIV scientist and researcher, and she'll be giving grand rounds for us on November 5th, so it's definitely not one to miss. Speaking of not ones to miss, today we have one of our own, Dr. Matt Zipse, who is an associate professor here in the Division of Cardiology and an electrophysiologist. He many times doesn't need an introduction. Everybody knows him well, but I will continue as well. Dr. Zipse did his undergrad and his medical school at Indiana University. He then came here for internship, residency, fellowship, and then EP fellowship here at the University of Colorado. His clinical and research work focuses on arrhythmia management, device therapy, and innovative ablation techniques. He's had multiple publications, and many of them explore topics such as VTAC, ablation in complex patients, and novel approaches with devices and resynchronization. Beyond clinical practice, Dr. Zipse is the program director for our EP fellowship, and he was also inaugurated as in the first class of Clinical Excellence Society members approximately a year and a half ago. He's also an active contributor at the national scene in the American College of Cardiology and the Heart Rhythm Society. He's authored many publications and is well known nationally. So please join me in welcoming Dr. Matt Zipse.
Thank you, Eddie, for that very kind introduction. I hope this will be a fun talk today. It'll be a review of what we are currently doing in the EP lab, some indications for your patients that might prompt you to refer folks to us, and a little bit about the future of arrhythmia management. And this is a device-based talk. These are my disclosures here. So today we're gonna review ambulatory cardiac monitoring, both consumer wearables and the role of consumer wearables, and perhaps some times where consumer wearables may lead us astray, as well as prescribable ambulatory cardiac monitors and what to do with these data. We'll review indications for pacing and defibrillator therapy for your patients. And I'll review where we've been when it comes to cardiac rhythm management devices and where we perhaps are going in the future. So this is our set list or our talk outline, and we'll dive right in. And I was asked to start with a case. And the case I'll start with actually doesn't come from my EP lab or my clinic. This is a case from TikTok, okay?
So I'm just getting out of the hospital. My Samsung watch last night when I woke up at 3 in the morning was telling me I'm in AFib. And I checked the health app and it says do an ECG, so I do one. And it confirms that yes, I am in AFib. So I called 911 immediately because it's the first time this has ever happened. But thank God I was wearing my watch because I wanted to know what sleep animal I was. Because after 7 days of monitoring your sleep, it tells you what animal you are, and I'm a deer, but I also have AFib, so LOL.
So there you have it. Original indication was monitoring evaluation of sleep animal phenotype, and we end up diagnosing atrial fibrillation. So this is all over social media. Our patients are using these wearables. What's the role, and when should they be using wearables? And I guess that question of when and our advice to patients, is it even relevant in 2025? Because these devices are ubiquitous. Many of you are wearing them. Your patients are wearing them. We have this proliferation of wearable technology, and we have the lay press that is constantly feeding our patients and folks in the community with these reports of how these devices are saving lives. And so this is big business. A $12 billion business just 2 years ago, estimated to become a $112 billion business in the United States by 2033. And so is this a good thing? I don't know. I suppose it depends on your perspective. The Apple Heart study suggest that these devices work relatively well at diagnosing arrhythmias, in particular atrial fibrillation. And there was an 84% concordance with an irregular rhythm detection on these monitors with AFib on a follow-up Holter. And maybe there's a rationale for widespread, effectively what is becoming widespread population screening for atrial fibrillation. There's 53 million people worldwide living with AFib. AF is associated with an increased risk of morbidity and death. And so if we can diagnose our patients earlier in this disease process, perhaps we could prevent strokes, perhaps we could allow for treatment to prevent AF progression. The issue is that multiple non-randomized and randomized studies when it pertains to widespread AF population screening really have not shown clear benefit for this strategy, mostly because event and stroke rates are low across the population. For instance, in the Apple Heart study, which really was a feat of patient recruitment, 411,000 patients were enrolled in the Apple Heart study in a matter of months just by sort of agreeing to the terms of service when patients bought their watch. Mean age of 41 in this population. And there's some costs that go into managing false positives, and that those could be substantial. And there's a potential for unnecessary testing and treatment and managing what turn out to be true positives in otherwise young, healthy patients who may have subclinical AF and may otherwise not have presented. There are populations of patients, of course, where the stakes are much higher, particularly in patients who have had a prior stroke. And we want to monitor those patients and do surveillance for AFib because that's very much actionable. In our device clinic population, all patients that have pacemakers and defibrillators, there's a deluge of data that comes with these device interrogations and remote monitoring. And so these patients effectively have continuous cardiac monitoring, and the incidence of arrhythmias is high even in patients who previously weren't diagnosed. And of course, it's worth using ambulatory monitoring regardless of strategy, whether it's a consumer wearable or prescribable monitor in our patients who have symptoms. When you're concerned about symptoms of bradycardia, palpitations, symptoms of tachycardia, though as Ben Steinberg has published on, the correlation between symptoms and arrhythmia in our patients often is imperfect at best. So how do we monitor our patients' heart rhythms? Well, I've already mentioned consumer wearables, and the way that many of these devices work is that they use photoplethysmography. So there's a light detector on the back of the watch or the wearable that's detecting the regularity or irregularity of the pulse, and then it can alert or prompt the user then with a confirmatory ECG. But there's lots of different strategies for this. This is another device that many of you may have encountered called the Cardia mobile device. And the newest version of this actually can provide really what amounts to a diagnostic quality 6-lead ECG by electrodes on this device and a 30-second tracing. This is an ECG strap that is intended to be worn even with exercise. And to the delight of healthcare providers everywhere, this company advertises that the ECG can be live streamed to your doctor's office. So we can all sit there while our patients are training for their Ironman and watch their live telemetry while they're exercising. These devices don't always quite achieve what they intend. So I remember about a year ago, my mom, who has insomnia, bought an Apple Watch and was using it, hoping to use it to monitor her sleep quality. And she called me maybe a week later and said, this thing is every hour through the night waking me up and telling me it's time to stand up and move around, right? So I went on to, it turns out that, we don't always hit the mark and why, the purpose of these devices. And I would also make the point that not all wearable technology is created equal. So this is a ECG that was posted on social media of a patient in rapid atrial fibrillation, though the PPG heart rate sensor on the back of the watch obviously is quite inaccurate. And I think it's worth just driving home that point because it can lead to a lot of confusion. You know, photoplethysmography, the underlying mechanism is that it's trying to detect arterial pulsations and estimate the pulse. And that's imperfect. The gold standard for heart rate and rhythm obviously is the ECG. And comparing these two types of tech is a little bit like comparing the quality of play in the first 3 quarters last Sunday for the Broncos to the quality of play in the final quarter. And so there's a pretty big discrepancy in how accurate these things are and the quality of data that we're getting. So to illustrate this point, this is a case. It's a case of a 59-year-old woman who was having intermittent palpitations and saw her primary care provider and was having symptoms about once a month, had a couple monitors along the way that really didn't show anything, but she didn't have symptoms during the monitoring period. So we don't know. Workup involved an echocardiogram, which was normal. And after discussion, they opted just to try sort of empiric metoprolol. And she continued to have periodic palpitations, but the symptoms associated with the palpitations were less severe. The patient went to get an Apple Watch and immediately within a day was receiving low heart rate notifications during the daytime. The patient sent a message through My Health Connection to their physician that they were getting low heart rate notifications, and so the beta blocker was stopped, and then the palpitations were worse again. Okay, so this is a case where the patient's not having symptoms of bradycardia, they're having intermittent palpitations. And so what's going on here? Patient came in for an ECG, and this is what we've got. So I'll kind of walk you through this. So this is sinus rhythm with patterned ectopy, and the computer has read this as ventricular bigeminy, but I'll try to convince you that there actually is a P wave in that T wave. And so this is atrial bigeminy, and it kind of gets at a potential mechanism for what this patient's experiencing. I'll say she wasn't symptomatic during this ECG, but this is probably why the watch was alerting for a low heart rate. And there's actually probably 2 mechanisms. One is that the bigeminal nature of her rhythm and the premature beats with a reduced stroke volume weren't being picked up by the PPG sensor. And so it was detecting her heart rate as actually half of what it truly was. The alternative explanation is perhaps occasionally she had blocked PACs, but this is a point that I want to drive home because I think every year multiple patients are sent to the ER from clinic because of reports of bradycardia, and we don't have an ECG, and they get to the ER and they're in ventricular bigeminy and they're not symptomatic. So make sure to get ECGs on your patients. That goes for wearable tech as well. So in this patient's case, an additional monitor was ordered, which ultimately diagnosed symptomatic paroxysmal atrial fibrillation. And that was the cause of the symptoms all along. The low heart rate notification was a red herring, but did get into the mechanism. For those of you interested, those PACs I showed were actually mapped to her right superior pulmonary vein and a potential trigger for her AFib. Okay, so compare that tech and contrast that to where we started. And this is Jeff Holter from 1947. And perhaps Jeff was onto something here. Specifically, I think if you're evaluating your patient for syncope, just make them carry around an 85-pound pack, and you'll be quite likely to capture a syncopal episode during the monitoring period. But this is the original Holter monitor. And we've come a long way, of course, and you guys are familiar with these devices. Many times these days, the prescribable ambulatory monitors are in a patch format. They're waterproof, patients can shower with them. They have a symptom trigger or a button they can press that flags symptoms on the report. These devices can be in a form where the monitoring is retrospective, which I would advocate for. I think it's pretty rare that we really need mobile telemetry, and that adds, of course, to the calls and the data deluge that we're dealing with these monitors. But in any event, we can correlate symptoms to arrhythmia with these monitors, and these monitors can direct care. Occasionally, we implant monitors. Implantable monitors have come a long way from fairly large devices that were implanted with surgical electrocautery in the way that we would implant a pacemaker. These days, implantable monitors are roughly the size of a paperclip, and they're injected under the skin through a little 1/4-inch nick in the fourth intercostal space. And we get a lot of good data from these monitors with a battery life of 3 to 5 years. We often place these for patients who have cryptogenic stroke for AF surveillance, but occasionally we'll place them for patients who are having very rare palpitations without a documented arrhythmia on prior ambulatory monitoring. And then occasionally we also use them for surveillance in patients with inherited arrhythmia syndromes. So these types of devices, implanted monitors, as well as pacemakers and defibrillators, they're constantly recording the heart rhythm. They store all this data, and they transmit it to us in our device clinic. And there was a time where I thought this was like this seamless process where the patient was just transmitting this data sort of almost continuously, and somebody, I don't know who that is on the right, maybe that's supposed to be me, is just watching all the time, akin to like a telemetry technician. But of course, that's not how this works at all. Data transfer happens at pre-specified intervals for pacemakers and defibrillators, usually every 3 months. For implanted cardiac monitors, usually once a month. These devices, most of them can push a transmission or an alert if certain criteria are met, like AFib for a certain duration, bradycardia, tachycardia, arrhythmia events. And we often, but not always, get those alerts, so to say, the next business day. But it's a complex system, and there's lots of people that are sort of in between the patient and us and our in-basket. These alerts, there's a lot of noise with these alerts, a lot of things that are not actionable that we have to sift through. This is a case that I wanted to highlight that just was transmitted last month in a patient. The alert was for bradycardia and a pause. And you can see this was at 11:50 p.m. And you can see the indication for this patient's implantable monitor was cryptogenic stroke. And this is a patient who had known sleep apnea and he wasn't wearing a CPAP. Okay, so this comes up all the time. You see this on monitors that you order. Nocturnal bradycardia while asleep should prompt an evaluation for sleep apnea. And it would be very unusual that patients would have a pacing indication for nocturnal pauses. So just to review, when do we pace? You guys know this, but we pace, or patients have an indication for permanent pacing, at least when it comes to sinus node dysfunction, when they have symptoms of bradycardia or pauses. And to have symptoms, last I checked, you need to be awake. Okay, so nocturnal pauses, not an indication for permanent pacing. The other indication for pacing is when patients have evidence of infrahissine conduction disease, Mobitz 2, high-grade AV block, complete heart block, not attributable to reversible or physiologic causes. And that could be things like drug toxicity, beta blocker DIG toxicity, metabolic derangements, rarely Lyme, but most commonly vaguely mediated. For instance, in a young healthy person who's having intractable nausea and vomiting, if that person was wearing a monitor, it's not unusual to see P2P prolongation, Mobitz 1, and then AV block. And that doesn't necessarily represent, it doesn't represent pathology or infrahissine disease. But outside of those reversible or physiologic causes, infrahissine disease is an indication for pacing whether or not patients are symptomatic due to the high incidence of syncope and sudden death otherwise if these patients aren't treated. So how do we pace? Any sort of talk that involves a new or disruptive technology or paradigm shift deserves a timeline slide. So where did pacing start? It started in the 50s. And this is Medtronic's founder. And the first patient, the first pacemaker was really modeled, interestingly, off a metronome's blocking oscillator circuitry. And that's effectively what this patient is wearing with a transcutaneous electrode. And we've come a long way, obviously, since then. We've had a lot of advances, but for the most part, the paradigm for permanent pacing has been the same. There's an intraclavicular pocket where there's a pulse generator and transvenous leads that are implanted in the heart. And we have had lots of innovation between the 60s and time present in how pacing happens. But over that time, because the paradigm has been essentially the same, we've had the same sorts of complications that we've continued to deal with as it pertains to the pocket, and perhaps even more importantly, the transvenous leads themselves, which are really the Achilles heel of a pacing or defibrillator system. There's a risk of endovascular infection. There's a risk of lead malfunction, lead fracture, insulation breach over time. And these leads don't last forever. And so then we have to deal with lead malfunction and or infection. It turns out that infections are becoming more prevalent amongst implantable cardiac devices. And that's likely because the systems are becoming more complex and patients are becoming sicker that we implant these devices in. One of the points I wanted to drive home today is if you have a patient who has bacteremia without a source and they have an implanted cardiac device with transvenous leads, that could be a big problem, and we should be involved in that patient's care, because many times they'll have an indication for lead extraction where we have to remove the leads and hardware, even if the TE doesn't necessarily show up vegetation, because there can be a biofilm that develops on this hardware, especially in patients who have Staph aureus. And the earlier that we can get source control by removal of hardware, the better the patients do. This was a QA/QI project that we did a few years back, where we went to Epic and said, we need to be able to identify infections in patients who have implanted cardiac devices sooner in their hospital course. And so there's a best practice alert that fires and comes to our in-basket when patients are followed at our device clinic and we know they have transvenous leads and they show up to the hospital with bacteremia. There are a lot of false positives here, but occasionally we save some near misses. And when devices are infected or when leads malfunction, sometimes we have to take them out. And so I specialize in lead extraction, which is a procedure that's highly technical, but it involves essentially using either a mechanical sheath or a laser sheath to dissect leads and adhesions away from the vasculature in the heart itself. And this is a procedure that carries rare but real risk of vascular tear and cardiac perforation. And so lead extraction procedures really are a multidisciplinary effort. This happens to be an image from across the street at Children's Hospital, where I also do lead extraction. And there are almost innumerable people involved in making sure these procedures go as safely as possible. But it involves cardiac surgical backup in the event of complication and all the people that would be needed to get a procedure done safely and effectively. So getting back to lead complications and the way pacing has been done historically, it's in that context that in the last 9 years, we've had the arrival of leadless pacemakers, which are essentially everything I've just described, miniaturized and in sort of a capsule. And there are 2 manufacturers that make leadless pacemakers that are FDA approved. The concept is similar for both. The original generation of these devices provided only ventricular pacing without the ability to track sinus rhythm and maintain AV synchrony. But each manufacturer has had their own approach in subsequent versions to try to maintain AV synchrony. This is kind of cool how Medtronic does it. They leverage the accelerometer, a 3-axis accelerometer on the leadless pacemaker to sense atrial mechanical contraction and the small displacement of the device that occurs in sinus rhythm with atrial contraction. And then that allows for P-synchronous ventricular pacing. It works okay. For active individuals, it tends to fall apart at faster heart rates, but for some patients, it's a good option. The other manufacturer really has come to market in the last 2 years with true dual chambered leadless pacing, where there is a atrial leadless device and a ventricular leadless device, and these devices can talk to each other using a Morse code of sorts, subthreshold pulses that are detected sent back and forth. And this is how the devices communicate with each other. And these devices work pretty well, but there are some limitations. I found probably one of the nicest uses for this type of device is in patients with sinus node dysfunction and implanting an atrial-only leadless pacemaker. So this was a case that we did of a patient who had a transvenous device and was having symptomatic SVC syndrome from vascular occlusion, which is a rare complication of transvenous leads, but happened in this case. And so the leads were removed and she got an atrial leadless pacemaker. It makes sense that leadless pacemakers from a complication risk profile standpoint, we don't have pocket infections, we don't have lead related malfunction. And so in some sense, leadless pacemakers have a favorable risk profile. But they aren't without all issues. And this was a case referred to me of a patient with a leadless pacemaker implanted elsewhere, where the leadless pacemaker was implanted and causing severe tricuspid regurgitation because of its location of implant. And so they can be retrieved. And this was a case where we retrieved this device. But retrieval can be challenging, as you could imagine. And we don't have long-term retrieval data for these patients. And it's possible that sometimes these devices may fully endothelialize and be difficult to retrieve. Patient selection is key. Leadless pacing is not for everybody, but in select populations, it can make a lot of sense. I want to spend a little bit of time on cardiac resynchronization and perhaps more importantly, physiologic pacing or left bundle pacing. Just show of hands, who's heard of left bundle pacing or conduction system pacing? Okay, good. So I'm glad I'm talking about this today, because this, in a matter of a short period of time over the last 5 years, has become how almost all of our patients are getting pacemakers in our EP lab. So I'll set the stage with a case. This is a 71-year-old woman who presented in February of 2018 with AV block and was symptomatic, had an escape, a normal ejection fraction, but got a routine dual chamber pacemaker. Was discharged, did fine, but in follow-up was noted to have mild LV dysfunction. And then a year later, began complaining of symptomatic heart failure, and a repeat echocardiogram showed that her ejection fraction had dropped even further to 35 to 40%. So what's happening here? This is a problem that occurs in select patients who have sort of a standard RV lead with RV apical or septal pacing. And the issue is dysynchrony. So when you pace the right ventricle, what you're essentially doing is giving somebody an iatrogenic left bundle branch block. You have dysynchronous contraction of the left ventricular free wall. And in a proportion of patients, that's associated, so that decreases the efficiency of LV contraction when we have dysynchrony, and in a proportion of patients, they develop heart failure. We know that RV pacing is associated with adverse outcomes in select patients. And that's probably to the tune of about 12%. But looking at different studies, what happened to this patient might happen anywhere from 9 to 30% of the time, where somebody develops heart failure because of RV pacing. And in the same way, a left bundle branch block causes LV dysynchrony, where you have activation down the right bundle, myocyte to myocyte conduction, and eventually activation of the LV lateral free wall. And that dysynchrony, in a similar sense, can actually cause a cardiomyopathy, a left bundle branch block associated cardiomyopathy. This was a study, a really nice study published just in the last few months from UCSF and Greg Marcus's group. And it's a population-based, it's a cohort study, a prospective cohort study where they followed patients with narrow complex ECG, left bundle branch block ECG for 15 years. And they found a 5-fold increase adjusting for all of the factors of heart failure in patients just because of a left bundle branch block. And so dysynchrony can be a problem. And historically, the answer to a patient like this who has dysynchrony, heart failure because of RV pacing, was to do a device upgrade and do what's called cardiac resynchronization therapy. And so what CRT is leveraging the anatomy of the coronary sinus to implant a pacing lead in a coronary sinus ventricular branch vein. And what that does is allow for pacing simultaneous of the LV free wall and the septum and resynchronization. And this technique of CRT is highly effective to the tune of probably 70 or 80% of resolving heart failure in patients who have a pacing-induced cardiomyopathy or a pure left bundle branch associated cardiomyopathy. But it doesn't work for everybody. And for all comers who have a CRT indication, about a third of patients don't respond. And some of that is because it's technically hard to do. Not everybody has suitable anatomy. This is what this looks like in the EP lab as we implant one of these leads. And this was a really challenging case where, we're sending a wire through collaterals and snaring it to create a rail to deliver a lead. So this isn't always possible. And even when you get a lead in position, sometimes the electrical function of the lead on the epicardial surface of the heart from the coronary sinus is not going to, is associated with high pacing thresholds and not suitable for long-term pacing. So in 2015, 10 years ago, we started looking at conduction system pacing. Could we, instead of just pacing the right ventricular apex, could we pace the His bundle or the electrical output of the AV node beyond the area of AV block and leverage the fascicular system to avoid this problem of dyssynchrony and heart failure? And so His bundle pacing was in vogue for literally about 2 years. And it worked, but it was very difficult to do this and do it well. And the leads tended not to be very stable at the tricuspid annulus. We had lead dislodgements, need for lead revision, high thresholds. And so in 2017, Weijing Huang in China was the first to describe moving this lead into the ventricle and achieving fascicular capture of the left bundle branch through deep septal fixation. So we fixed the lead deep into the interventricular septum and captured the left bundle branch or the fascicles associated with the left bundle and achieve resynchronization this way. And so in your standard patient who's coming to our EP lab these days, who's getting a dual chamber pacemaker, this is the default strategy. And it's really only been in the last 5 years that we've been doing this. And this will avoid the issue of heart failure in our patients who have AV block. This is what it looks like in the EP lab. So we have a catheter-based sheath and we're turning this lead and it's literally drilling into the myocardium to the LV subendocardium and capturing fascicular tissue. In this patient that I described, we tried CRT, but the thresholds were high, and so we employed this strategy. And here we're giving contrast, and you can see the contrast opacifying the RV endocardium and the surface of the interventricular septum. We pace when we fixate these leads, and we watch the QRS morphology, and this is what this looks like. So over time, the lead we're achieving deep septal fixation, and you can see the QRS is narrowing, and we start to develop an R prime in V1, similar to a right bundle branch block pattern, because we're pacing the left fascicles. And if you compare what pacing from this lead looks like to the patient's right ventricular lead, you can see it's a narrow QRS, and there's ECG evidence here of engagement of the conduction system. This is what that lead looks like on echocardiogram with deep septal fixation. This is this patient's follow-up ECG, and within months, a repeat echocardiogram showed that her ejection fraction was now normal, symptoms of heart failure resolved. So this is a compelling technique and an alternate to traditional RV pacing that's become ubiquitous in our specialty. And it may have a role as an alternative to traditional CRT as well in patients who have left bundle branch block. How does that work? Somebody has left bundle branch block, you're going to pace the left bundle, but it turns out most left bundle branch block is proximal in the fascicular system, and so we can pace distal that and achieve a narrow QRS. Not always, but sometimes. This is a patient with a baseline left bundle branch block. We start pacing with lead fixation, and you can see as the lead is fixed, we start to develop an R prime in V1, the QRS is narrowing, and we ultimately leave the lead in this position with a narrow QRS, particularly when comparing and full correction of this patient's left bundle branch block. It almost looks like an incomplete right bundle, the paced morphology. And this is the patient's follow-up ECG. So QRS of 144 with a milliseconds with a left bundle, narrow QRS with pacing. So the bottom line is this is a promising technique which leverages the physiologic conduction. It's not always possible to achieve true conduction system capture. And I will also say that when it comes to it as a technique, as an alternative to traditional CRT, we have a paucity of data, and there are randomized studies ongoing. This is a shameless plug that we're enrolling here actually in a study that's evaluating CRT versus conduction pacing or physiologic pacing of the left bundle. Let's move on to defibrillators. Defibrillators have seen big changes and paradigm shifts and disruptive technology in parallel with pacing. The story of defibrillation dates back to the 70s. Morosky and Morty Mower developed the initial automatic implantable defibrillator. And their work was met with a lot of resistance in our field. Folks were very skeptical that a defibrillator could be implanted and could effectively save somebody from a cardiac arrest. There were editorials written that we would be electrocuting our patients, and this just wouldn't work. And so they pushed through that resistance. And in 1980, the first defibrillator was implanted in man. Now, the first defibrillator looked nothing like defibrillators you've become accustomed to. Abdominal generators implanted with a thoracotomy, epicardial patches, which allowed for defibrillation. The transvenous systems first began to be implanted in 1988, but those also didn't look like what you're accustomed to. Still very large abdominal generators, coils that were implanted into the vasculature to achieve effective defibrillation. And then from there, we've had a lot of developments, and we've come to ICDs in the way you appreciate them today. Also involving transvenous leads and all the potential issues that we talked about with transvenous leads. And so it's in this context that we've had some new defibrillators that undoubtedly you've seen in some of your patients. The subcutaneous ICD is an axillary generator with a lead that's tunneled under the skin in the adjacent to the sternum, and has been shown in randomized studies to be non-inferior to transvenous ICDs. The advantage of the subcutaneous defibrillator is that it could be removed easily. And so we consider this device sometimes in very young patients who require an implantable defibrillator. It can't provide pacing, and importantly, therefore, it can't provide anti-tachycardia pacing, which in patients with monomorphic VT can be a way to terminate an arrhythmia without requiring a shock. It's also a larger device. It's about the size of a deck of cards, and it's heavier and has a shorter battery life. This is not yet FDA approved, but there's a system that can allow for modular ATP where this device can pair with a leadless pacemaker, and that will likely be commercially available yet this calendar year, and that can be an option for some patients. A competing manufacturer has developed the extravascular defibrillator, and instead of the lead being tunneled under the skin, the lead is tunneled retrosternally. And so a small incision is made in the subxiphoid space. The generator is still in the axillary position, but then the lead is tunneled behind the sternum. And the advantage there is because the lead is closer to the heart, coils are closer to the heart, you don't need as much energy for successful defibrillation. And so the generator can be smaller. And then also because it's close enough to the heart, the device can provide some rudimentary pacing, including anti-tachycardia pacing. So this is another nice option for young patients and especially slender patients. This is what an implant procedure looks like with a tunneling tool that's placed under the sternum, slides underneath the sternum. That tunneling tool is removed and the lead is inserted and unsheathed, tied down, and then a second pocket is made for the generator. So this is the extravascular ICD. The first patient in Colorado, I went over to Children's Hospital and helped implant one of these, was a 17-year-old high school track athlete with long QT syndrome 2 and many risk factors for ventricular arrhythmias. And this was a really nice option for him. He's back literally on the track within a couple of weeks. And he, I think, finished second in the state on his 1600 relay or something like 4 months later. So it's a nice option for some patients. The inappropriate shock rate is still higher than I think it ought to be, though this is improving with improved programming. The ATP can prevent shocks at about 2/3 of patients with ventricular arrhythmias. And so it's a nice option. Let's talk briefly about where we're going with implantable cardiac devices. So what's the future of ICD therapy? I suspect that it will continue to shift towards extravascular, extracardiac devices, continued miniaturization. This is a prototype of a device called this quote unquote string ICD, and this is rechargeable. It's obviously not FDA approved or ready for commercial use, but it just goes to show that that I think we can anticipate continued miniaturization of these devices. I also suspect that device diagnostics will continue to improve, as will predictive analytics for how these devices deliver therapy and anticipating when a patient may have ventricular arrhythmia so that interventions can happen. And perhaps the biggest unmet clinical need in our field is improving patient selection and our ability to assess risk of sudden cardiac death. ICDs are ubiquitous. In the United States, there's somewhere between 800,000 and 1 million patients that are living with a defibrillator, 150,000 annual implants, but not everybody needs therapy. In fact, the majority of patients who undergo primary prevention, defibrillator placement, never need therapy. And I like this diagram. This is a famous figure from Meyerberg that plots on the left the incidence of sudden cardiac death in various populations, and on the right, the absolute numbers of sudden deaths. And what we see is that our traditional defibrillator population for primary prevention, who demonstrate an ejection fraction of less than 35% or less despite 3 months or more of optimal medical therapy, the incidence of sudden death in that group is higher. The absolute numbers are low. And as I just said, not everybody ultimately has ventricular arrhythmias. And that's also a very heterogeneous population. We're just 35%. That's a number that's been informed by large randomized clinical trials of 20 years ago. But the risk profile for a patient who's had a myocardial infarction, has extensive fibrosis, an LV aneurysm, and an EF of 10% is very different than a non-ischemic cardiomyopathy patient who does not have LGE or fibrosis on an MRI and has a left bundle branch block, and you might expect would respond to CRT. So very different risk profiles. MRI can help us stratify risk, but how do we identify these patients? I don't know. And I think that's, once again, a major unmet clinical need. I asked ChatGPT to create an image for me of a tool to assess and predict sudden cardiac death. And this is what it came up with. It's made in my likeness. This is me, I think, at a carnival with a crystal ball, and people are sort of coming up, and the title there, it doesn't project, says, come predict your cardiac fate. So people are coming up, and so it's clear we have a ways to go when it comes to sudden cardiac death risk prediction. We spent a while talking about pacing. I think we'll continue to see physiologic pacing moving forward. We do need improved tools and devices. I think we'll very soon see leadless physiologic pacing, where leadless devices can be implanted and engage the fascicular system. We'll continue to see novel battery technologies and ways to power these devices. You can imagine different paradigms of leadless devices that could provide CRT, but this can become clunky. These devices all have different batteries that will need to be exchanged at different intervals, and can they be retrievable? You know, and perhaps a better paradigm might be a parent device with a battery and receivers. And then the receivers are there forever and endofibrose and are small, and then a parent device can power these receiving pacemakers. And there is one particular device that sort of follows this kind of paradigm. Wireless recharging. This is not new technology. we all use it all the time to power our phones and our devices. So why don't we have this with implantables? This is a paper I found from 1965 talking about externally recharging our pacemakers. It begs the question, why hasn't the tech progressed? And I think that there are multiple potential reasons for this, ranging from paternalistic, are we going to trust our device-dependent patients to reliably recharge their device, to perhaps more skeptical in that there's undoubtedly market forces that are at play that influence how manufacturers are allocating their R&D dollars. And the reality is that device generator changeouts remain a source of revenue for industry. So how are they going to allocate their funding for R&D? There may be some logistical issues with tissue heating and so forth, but people are working on this, including consumer companies. So this is a patent I found a few years back when I was doing a search. This is Samsung, and this is a patent talking about recharging devices. So recharging your phone wirelessly, recharging your hearing aids wirelessly. Perhaps someday we'll be able to pull our EV into the garage, and a plate on the floor of the garage will recharge our electric vehicle, and we won't need to plug it in. We already have the tech that we can use one device to recharge another. And so perhaps we could use our smartphone to continuously charge our pacemaker. It's compelling, but this is the sort of thing that companies are working on. I think this is also compelling. This is obviously old technology, harvesting kinetic energy. So this is an oscillating weight in a Seiko wristwatch, and it's used to power the watch. Okay, so 30 years ago, this Japanese group sort of drew out a blueprint for how that might look to power a pacemaker. Can we harvest the energy of cardiac motion to power a pacemaker? And not to be outdone, the watchmakers of Switzerland followed that up years later with their own sort of version, where they literally took a wristwatch and wired it to a rudimentary pacemaker and showed proof of concept, of course, not ready for clinical practice, that you could pace harvesting, and that pacemaker could be powered by the oscillating weight of a watch. So I think that it's an exciting time. We've got lots of technology that's coming to market. We've really reached the golden age, I would say, of cardiac devices with recent disruptive technologies and techniques. We touched on leadless pacing, physiologic pacing. We talked about extravascular defibrillators. And I think I'll conclude there with the future is bright. And I'm certainly excited about it. I hope you are too. This is my daughter, and she's learning how to implant a retrosternal electrode for an extravascular defibrillator in a simulation here. I'll pause there and take questions.
Thank you, Dr. Zipse. That was incredible. I'm sure they will stimulate plenty of questions. We have one right here. All right.
What a wonderful talk. Thank you. How do you approach atrial fibrillation subclinical detected on implantable devices or smartwatches when it comes to recommendation regarding anticoagulation?
That is an excellent question, and one that I probably could have devoted the entire talk to. The talk wasn't one on AFib, but wearable tech, so I glossed right through that, but that is a question I think we all struggle with. There were two recent randomized studies that tried to address this issue that you speak of, NOAA and Artesia, and they took patients who had subclinical atrial fibrillation, for the most part detected on implantable devices, and they randomized them to anticoagulation or not. And they got discrepant findings between those studies. Meta-analyses of these studies suggest that there's still benefit if you default to the CHADS-VASc score on decision-making, but there's no doubt that patients with subclinical atrial fibrillation who are not coming to your office complaining of palpitations and getting an ECG with AFib documented, but detected on these devices, are at lower risk of stroke. And so we're balancing that smaller potential for benefit with anticoagulation against the risk of major bleed. And there may be a small benefit, but it's not as much when you compare to patients who have clinical atrial fibrillation. My thought is that, in my opinion, is that a lot of these patients, the overall burden of atrial fibrillation is much less in patients who have subclinical AF compared to patients who we're seeing in our clinics. And burden of atrial fibrillation does not appear in our CHA2DS2-VASc risk score, and it probably should. And so I think that's another area of our field that's ripe for investigation. And there are ongoing studies to try and help address this very issue.
Matt, leadless pacers are incredibly, advancing the field here. Can they get infected by themselves? And if so, you talked about the challenges of extraction.
Yeah.
What do you do when they do get infected?
Yeah. So the answer is yes, they can, but it is incredibly rare. And there are a lot of reasons, I think, why we don't see leadless pacemaker infections. I have yet to see one. They've been published. There are case reports of these things. I think the reasons why we don't see nearly as many leadless pacemaker infections are that it's a smaller surface area device. The devices go into the right ventricle where there's turbulent flow. The devices are not handled by us at the time of implant. So they come in sterile packaging, and we load onto a catheter without having to manipulate the device, and they go directly into the vasculature. And then they have a sort of a antimicrobial coating that can help as well. So all these things are reasons why we see less leadless pacemaker infections. And in fact, that's a patient population where we commonly consider leadless pacing, and that would be patients that are at high risk of infection. They've had prior sepsis, bacteremia, end-stage renal on dialysis, prior lead infections. And so I think those are good patients to consider these devices for. When it comes to retrieval, I think it's possible. One of the devices I showed is designed to be retrieved. There's a retrieval catheter. The other device doesn't have a retrieval catheter, and so you have to sort of snare it with off-the-shelf tools that we kind of MacGyver into a fashion to take it out. But as I showed, unpredictable, I think, at 8 years, 10 years, 15 years, if we can retrieve them without needing to do surgery. When I posed this question to Medtronic 12 years ago, when Micra was being released, they countered with a cadaveric study that showed that the average right ventricle can accommodate 3.4 leadless pacemakers. And so we can just, when these batteries die, just put another one in. And so for that reason, the battery issue sort of lends itself to, we don't implant a lot of leadless pacemakers. We don't intend to retrieve in young patients.
Other questions? Todd Bull.
Matt, great talk. Really interesting and moving area. Regarding the AICD implantation that your daughter is so adeptly performing there. So is this general anesthesia? Is it more involved than a general AICD placement? Does that come into the decision on then who gets them, who's not? Or I guess trying to get a feel for, is this the direction we're going for sure? Or are there enough sort of downsides to it that the lead standard venous placement is still going to be there? So.
Great question. I would say that these devices are still version 1.0, and they have some downsides. And so they're not for everybody. But for select populations, young patients where you worry about whether the lead would last, a transvenous lead would last their lifetime, we consider these things. As far as the implant procedure itself, both the SICD and the extravascular ICD with the retroexternal lead are done under general anesthesia. I think the risk profile, it sounds, there's certainly when I began training and started doing the EV-ICD procedure, there's a pucker factor. We're not cardiac surgeons. We haven't been trained in that space, but it's very doable and very safe. I think there has been perhaps one reported case where a sternotomy was required because of ongoing bleeding. There have been reports of pleural and pericardial implants of the lead that were managed without a sternotomy. But in general, the retrosternal space is a potential space that the lead can be advanced in without any issues. So yeah, the safety profile of both the SICD and EBICD, I would say, are similar to a standard transvenous implant, just done under general anesthesia.
This is a much more basic question, but patients who come in who are wearing their Apple Watch and have something they saw and they don't know how to find it, is there guidance for patients or providers on how you can kind of look at that information and how to interpret it, where you could like send a patient who wants more information?
I think I think it's an area ripe for potential improvement, sort of systematic education for wearable devices. I think based on your question, the context is that the in-basket workload becomes substantial when we have our patients sending in questions, uploading tracings. I think some of this comes to managing expectations as well with our patients. That, you know, I have a small percent of my patient panel that just seems to want to send tracings around the clock. And I do think there's a role on our end for utilization of AI to sift through some of this and craft responses and be able to do a preliminary interpretation to help us. From a patient perspective, I often advise them. So I use wearables and I recommend wearables for a lot of my patients. You know, patients who have had AFib, we've done an ablation, we're doing AFib surveillance. I recommend them. I think the data in general is good that they provide, but I ask them to collect the data and make sure their phone is synced, and we'll review it at the next clinic visit and that sort of thing. So I'm not sure if that 100% answers your question. I don't have a perfect answer for your question.
Dr. Zipse, thank you for a great talk.
Yeah, thank you. Thank you.